Hello, everyone, and welcome to this special episode of Rigicon Talks. Today, we are joined by a panel of esteemed experts in the field of prosthetic urology who will share their insights on penile implants. Whether you're a patient considering surgery or a healthcare professional seeking an expert opinion, the discussion is packed with valuable information. We are fortunate to have with us internationally recognized experts. Professor Nuno Tomada from Portugal. Professor Tomada is a renowned urologist and andrologist with extensive expertise in sexual medicine, erectile dysfunction, and reconstructive genitourinary surgery. He is currently the president of the SPA Society, and with his deep involvement in academic research and clinical practice, he's a pioneer in the fields of prosthetic surgery, congenital penile curvature correction, and Peyronie's disease. Prof. Tomada, thank you for joining us.
Thank you, Yves, for the invitation. Thank you, Rigicon, for this opportunity to disseminate more of our education about penile implants.
Thank you. Our next guest is Dr. Gabriele Antonini. Based in Rome, Dr. Antonini is the leading expert in minimally invasive urological surgery with a focus on penile implants. He has gained recognition for his work in using advanced techniques to enhance patient recovery and minimize discomfort during surgical procedure. He is also a reference worldwide on the infrapubic approach when managing a penile implant surgery. And thank you both for joining us today. And thank you, Dr. Antonini, for taking time out of your busy schedule and joining us.
Thank you very much. It's a great pleasure for me attending this event. I'm very happy to share my experience with Rigicon and with my dear friend, Professor Tomada. Thank you again.
Let's begin our discussion with some common yet crucial questions that patients frequently ask you. They ask you both about penile implants. So many of them are unsure whether they're good candidates for penile implants. Professor Tomada, in your experience, who is the ideal candidate for this type of surgery?
Well, if I think the right patient is the motivated patient. So, of course, we know that we have the formal indication for penile implantation, or penile prosthesis implantation. That is the person with a severe ED that doesn't respond to the traditional treatments or has some kind of contraindication to the traditional treatments. And for many years, this was the natural way of doing penile implant. So we waited the time it was necessary for the patients to follow a number of therapeutics that were not working for the patient or causing him some kind of adverse events, or it was taking too long for the patient to choose the penile implant. Or in my experience, and I think in Professor Antonini, the same, many years we were taking care of our patients, giving them pills and then injections and then some devices, vacuum devices at that time. And patients were failing one after another, and it was very frustrating for us only having the opportunity to offer the penile implant at the last resource. Thankfully, today we changed our view, and worldwide we're informing our patients with erectile dysfunction that we have a lot of solutions for them, and one of them is the penile prosthesis implantation. So patient can decide up front if he can choose whatever he wants. If you want to take a pill, he can choose the pill, he can choose the cream, he can choose the injection, he can choose whatever he wants. But now he knows from up front there's another solution, definitive solution, with a high rate of satisfaction, both for patient and for partner. That is the penile implant. Saying that, it's also very important to choose the patient. So what is the right patient for the penile implant? And I can tell you that, as I was saying in the beginning, the motivated patient, so the one who wants to really improve the sexual life, his quality of life, is the patient that's going to ask us for the penile implant. And then we have to make sure the patient understands how it works and make him choose wisely which kind of penile implant, and then choose between the penile implants, which it will be better for him. Okay? So in a gross mode, I think the bottom line of all my saying is, until now, is the patient erectile dysfunction that is not responding to the other treatment, has some kind of contraindication or serious adverse event, is a good candidate for a penile implant, or the really motivated patient that wants a solution more definitive and more rapid, also is a good option for a penile prosthesis implantation.
Thank you, Prof. Tomada. Dr. Gabriele, I'll move to you. You have worked extensively on covering a holistic approach to the patient. So not only do you take care of his entire journey, but you also focus on the post-surgical function. So one of the key concerns that the patients share with us revolves around their sexual function after the surgery. Dr. Antonini, do penile implants impact the ejaculation or the orgasm in any way? How does it go for the patient?
But normally the ejaculation is normal after the penile implant. Obviously, it depends on the age of the patient. If we treat a young patient, at the end of the procedure, the ejaculation is completely normal. If you treat a patient after radical prostatectomy, for sure, the ejaculation is not present, and the patient normally is just a little old and can have some problem about the ejaculation, but is not directly correlated with the penile implant. I explained very well to the patient how the penile implant works. The final goal of the penile implant, I explain very well, the penile implant needs to have a strong erection. Everything about ejaculation is correlated about the relationship with the partner, and for sure correlated on the age of the patient. But normally everything is good.
So if the patient has not suffered from a radical prostatectomy, let's say if he's diabetic and he was still able to achieve some form of erection, it's safe to say that he will be able to enjoy an effective ejaculation and orgasm after penile implantation.
Yes, but sometimes the patient can have some neurological problem, because you know very well that the side effects of diabetic disease is a neurogenic situation, and the problem of the ejaculation can exist in this patient, but if you explain very well your focus, your goal is the erection, the patient at the end is very satisfied. And the relationship is very important. If the patient has a good relationship with his partner, and the relationship has a good sensation during the sexual intercourse, probably the patient has a normal ejaculation.
Thank you, Dr. Antonini, especially for setting the patient's expectations straight. It's important for them to reach out to you, the experts, and be able to have realistic expectations instead of harvesting info online and be deceived afterwards. So
this is the most important thing. If you don't explain very well before how is the final length, how is the girth, how is the sensation, how is the glance at the end of the procedure, probably you can't having the same result Otherwise, if you explain very well everything, the patient understood before everything, the final result will be perfect.
Thank you, Dr. Antonini. I'll swing back again to the first step, back to you, Professor Tomada. And I'll ask you about the preoperative recommendations that you give for your patients who are preparing for a penile implant surgery. How should they approach this important stage?
Professor Antonini just touched the right spot. We should inform patient and even the partner about everything concerning the penile implant. So this is a very difficult task. It seems simple, but it's very difficult because everybody knows that even if we are spending a lot of time and explaining how it works, how it will be the length, the sensation, the orgasm, the ejaculation, they will not remember all the things you are saying in the consultation. And when you are speaking about rates of satisfaction and about complications, they only hear about rate of satisfaction, never about complication. That's why I think in the preoperative recommendations, I always give my patients a copy in my language, in this case in Portuguese, of the SMSNA informative sheet for patients having a penile implant. So in this form, patients can have all the information, at least the most important information regarding what is the penile implant, what will happen to you, what are the most common complications, what will you expect after the surgery. And when they return for another preoperative consultation, I check that they read the form and they signed the form together with the consent, with the informed consent. So in this way, you can have all things covered: the expectation of the patient, the information that you should give them, so it's easier for them to understand how everything will come or everything will go in the preoperative situation. So that's how I prepare my patient. Specifically concerning the surgery, I don't have a particularly specific protocol, except for unbalanced diabetic. In this case, I usually use some kind of preparation with a skin preparation because they have higher rates of fungal infection. So usually I give them some kind of scrubs 3 days before they do a skin scrub. And in the pre-op, already in the operating room, I do the rest of the stuff that we can do, speak in the rest of the presentation if you want.
Well, both of you are extremely meticulous when it comes to this, and it reflects greatly in your extremely low infection rate, complication rate. So kudos to heavy preparations because they simply prepare for a successful outcome.
Okay.
Yeah. Well, again, in the stage of preparing this, the patients are often curious about the hospital stay. So you prepared them beforehand, they went through it, and the surgery happened. I'll go back to you, Dr. Antonini. So when the patients are asking about the hospital stay that's associated with the surgery, will the procedure typically require an overnight stay, or is it an outpatient procedure? What's the protocol at Crisisana?
Normally, I recover. I have the hospitalization for the patient is 1 night. The day after the surgery, I discharge the patient. And in my personal experience, because I have a lot of patients that comes from outside, I'm working in Rome, but I have patients from every part of Italy. I recommend to the patient to stay in Rome for 5-6 days in order to check everything better as possible, because the risk to have an hematoma, the risk to have some complication is very high if the patient move between, for example, Milan and Rome with the flight, with the train, or with the car. It's very important explain before this. I use a lot of video. I speak about this management, post-operative management with the patient during the first consultation, but in the time I send to the patient many videos where I explain how is day by day the post-operative time, and every day I check with pics that the patient send me with WhatsApp, how is the situation. I keep inside a drain for 3-4 days in order to prevent any hematoma in the scrotum. I keep inflate the prosthesis for 6-7 days to have an hemostatic works. And at the end of the first week, the patient can come back at home or to his personal work or his normal life. After 2 weeks, in my experience with the infrapubic approach, the patient can start with the first sexual intercourse.
Oh, that's a big investment in post-operative care. Thank you, Dr. Antonini, but this proves again that in the hands of experts, the patient is well taken care of. And that's why we usually encourage the patients to reach out to those who have the most experience so they can ensure an optimal outcome. And building on this, Professor Tomada, once the surgery is completed, Dr. Antonini alluded to the post-operative hospital stay. But in your experience, once the surgery is complete, how long is the total recovery period? And what should the patients expect in terms of physical, but also emotional recovery during this time?
It's a very important question here. So Gabriele already said he's experienced with the infrapubic approach, and it's very rewarding to see that in this approach that they start using the pump and having sex earlier than my favorite approach, that is the epinoscrotal. In my experience with this epinoscrotal approach, patients will have the cylinders inflated for 2 weeks. It's my usual time. So they'll get the penis straighter and with less fibrosis in the end, because I have a lot of patients with Peyronie's, so I have a lot of fibrosis as well. So it's a little bit painful in the post-operative situation. That's why they all have painkillers and anti-inflammatory drugs that work very well. They have the situation controlled in this way. And after the second week, we deflate the cylinders and they have a normal recovery. Up to the third week, they start to use the pump. And between the fourth and the sixth, they starting having normal sexual intercourse. Of course, in the beginning, it's very important to have the patients close by. That's why I only discharge them from the city, as Antonini was saying, after 3-4 days, because I have them with a very tight bandage that I only leave it, I only take it off at the 3rd, 4th day. So I don't leave the train, but that's another question. It will take another hour to discuss that stuff. But the main information for this talk is that both infrapubic or epinoscrotal approach, they have optimal and a great tolerated post-operative period as long the doctor is taking care of the patient. The bottom line is that we should be carefully watching for our patient, especially in the first week. After that, 1 week more, 1 week less, the approaches are almost similar.
Yes, I think, I think the patient need to be confident with his new erection and take the time he needs to restart. 1 week more, 1 week less is not important. At the end, the most important thing is the final result and refining the normal erection and the normal sexual intercourse for the patient and for the couple.
Completely agree. Completely agree.
Thank you. Both of you have an extensive experience in this. It still occurs to me that the patient's partner is sometime involved in this whole procedure, be it from the first contact to the surgery to the post-op. But sometimes the partner is completely absent from the picture. Dr. Antonini, you has tackled this quite a bit. From a partner's perspective, how does the sexual relationship evolve after the surgery? And do you happen to discuss the significant changes in the dynamic of intimacy, or is it left completely to the couple to figure it out?
I think the right question is how is the sexual intercourse or the relationship in the couple after the radical prostatectomy? Because after the radical prostatectomy with the oncological situation, because the patient thinking about his cancer, the relationship in the couple going down, and the patient become too much depressed. Normally, we have two kinds of patient. The youngest patient that come alone in the office for the consultation, asking the implant because he needs to start a new sexual life, a new relationship, and he is finding the new partner of his life. And the second patient is the patient after the cancer. And the cancer, you know very well, create a terrifying situation of depression, many problems, and the sexual intercourse doesn't exist anymore between the wife and is married. And I try to involve every time the partner, because I think it's very important at the end of the procedure, even the idea that the wife has of the implant. And I want to share the experience of other couples. I involve other men after penile implant, speaking with the new patient and the new couple, with the new wife that needs the implant in the next future. I think it's very important to involve the wife on this topic.
Thank you, Gabriele. Prof. Tomada, would you like to add anything? Same question.
Yes, I think we just that's very important stuff, a partner, because we have two different kind of patients. The one that doesn't care about their partner by itself. I mean, they have several partners, or they're waiting for a new relationship and they want to be confident with themselves. So they want to be able to have sex, to make love, and so they want a solution for that. And there's another patient that come within a couple and they feel ashamed and they are despair because they cannot have sex with their loved ones. And in this case, they come, or they should come, with a partner, because sometimes patients choose to do this situation. They don't tell the partner, and then very near the time of the surgery, already scheduled, they decide to cancel because they decide to tell the wife. She didn't know anything about the situation. She was not informed. And of course, she was convincing him not to do the surgery. So you should understand from the beginning what kind of patient do you have. The one that doesn't need to have a partner, or to bring the partner, sorry, or the other one that you should encourage to bring the partner to the consultation. And that's a feeling that you have after a few decades in this field, like Professor Gabriele Antonini. We know from speaking with the patient which one it will be, and we decide according to our consultation if we should bring the partner involved or not. So I think after a while, we have this already feeling when we are having our patient in a consultation, what way should we go with him?
Exactly that. And there are not enough studies that have been done regarding the patient partner satisfaction, since only one European study. But both of you gentlemen here on this talk have made sure that the preoperative stage and the surgical stage and the post-operative stage is handled by you and your team. And so, yes, we still see that some couples cancel or some patients cancel at the last minute, and it's still a big question mark. God knows if they're honest about it. But in both your experience as a closing topic, what does impact the cancellation rate or the cancellation urge at the last minute?
Gabriele, you want to answer that?
Yes, normally the patient has a lot of fear to change. The erectile dysfunction is a problem, but is a comfort zone, because I don't want to change my life. I don't want to change the relationship with other women, because I'm not motivated at the moment. The final decision is when the patient finds the perfect woman. And I remember very well many patients that come for the first time in my office for the consultation. Oh yes, doctor, I'm very motivated. I want the implant, and at the end they cancel the procedure. And after 1 or 2 years, they come back and ask me the implant, because finally they found the good girl to start a new relationship. I think at the end, the best reason or the only reason to have an implant is the wife or the man for the gay couple. And I think is the only motivation, the new relationship.
Yeah.
Thank you. Yeah. And I'll add something to you, Professor Tomada. There's a category that's marginalized because we tend to focus on the erectile function itself, but there are also couples who approach you, and by you, I mean they approach the experts to try to have kids or bear children the natural way. What about this category? And of course, what would you need to complement on Dr. Antonini's answer?
I don't know if I understand correctly what you were asking, but I think you were asking about couple that want to have kids, but he also want to put a penile implant.
Yeah, we talked about the category. Dr. Antonini talked about the heterosexual couples, but also the gay couples, and he said that finding the right partner and being ready for an active sexual life again after having lost your erectile function is the main reason. So it's the main driver for the patient to go approach you and say, okay, now I'm ready for a penile implant.
Yes. Yes, for sure. I have no doubt in my mind that the only reason for a man to change his zone of comfort, as Gabriele was saying, is to force him. Usually, the main drive is a partner. Women or men, it doesn't matter. It's a partner that is interested in him, and he wants him to have normal sex. Of course, having kids, maybe it's a supplementary reason, but usually it's a very small niche of men who are young want to have kids and also have erectile dysfunction. But it's very rare. Of course, it happens. We have some patients, of course, young patients with primary erectile dysfunction that, of course, would benefit a lot from a penile implant. But it's a very small amount of patients. It's very scarce. Concerning the driving force, for sure, it's always the partner. I never heard or had a man in my consultation that required a penile implant without having a drive, and the drive is always to please. I don't think it's to please himself, but to please others, wherever they are. So I agree with Professor Antonini.
Would you like to add anything, both of you, before we go to the closing remarks on this topic?
I would like to just to spark a little bit the conversation that it's interesting that you have here some experts in one approach or in another approach, infrapubic or pinoscrotal. They are doing both approaches when they need it, but they prefer one over the other for personal reasons, for teaching reason, whatever the reason it is. But it's interesting to notice that after our conversation, we all agree in the main topics, you know? So it's interesting, despite of the approach, we all agree in the preoperative and operative and post-operative approach of our patients. And I think that defines experts in this area, because we see a lot of patients with this complaint. We treat patients for many, many years. We understand the psychology behind it. So it's interesting to join us, me and Professor Antonini and Professor Bailey, in this conversation. So I thank you again for the opportunity.
Well, as the saying goes, all roads lead to Rome. So maybe our road will lead us to Rome, so we can do side by side different techniques. As you said, Professor Tomada, the technicality itself is proper to each surgeon. Once you have found the way that optimizes the surgical time, minimizes the risk of infection, and puts you at ease with the protocol, then our devices are in safe hands and the patient is ensured to have a safe outcome. Also, it depends on so many factors. We can have a complete session on this, on how to manage your OR and how to manage a high volume practice, like for all of you here. Especially, I saw days where Dr. Antonini had to do six patients in a row. So time is of essence. It's true that the infrapubic technique shaves off some time, but I'm sure that the technique that you yourself follow was greatly adapted for the complicated case that we did together. I think we spent 4 hours on a case, but that's what's required when you have to rework the patient 3 times.
Exactly.
My only desire is I would like the andrologist, or better, the urologist, change his way of thinking about the penile implant, because I think that the worst enemy of the penile implant in general is the urologist that not suggest to the patient this kind of solution. Normally, when the patient comes to his uro-oncologist, the request to have an implant is every time discharged, because the risk of the infection, the complication. I would like to have another approach by the urologist. I think the urologist needs to send to an high volume center this kind of patient to have an implant, because it's very safe in the right hands. It's not the last chance, because the penile implant, in my personal experience, is not a therapy on demand like the pills. Obviously, the pills works very well, but finally, the penile implant is the cure for the erectile dysfunction. It's not a on-demand treatment, it's the cure. This is my point of view.
No, absolutely. You're right, Dr. Antonini. And that's one of the objectives of the Rigicon talks, is to spread awareness not only to the patients seeking a solution, but also to other healthcare professionals, be it urologists, cardiovascular surgeons, diabetologists, oncologists, as you said, but mainly urologists who are not aware of a surgical solution, or as you said, are so not familiar with this solution that they would discard it for the wrong reasons. So both of you have participated and chipped in a big amount of experts' awareness around the topic. And we hope to keep, sharing your valuable expertise with the patients. Your insights have helped clarify many important aspects of penile implants for our audience. The patients reach out to the Rigicon portal on a daily basis, and we see recurrent topics coming to us. So now they're being answered by the experts themselves. To our viewers, we thank you for tuning in to this enlightening episode of Rigicon Talks. We hope that the information that we shared today with Professor Tomada, Professor Antonini, has provided you with a deeper understanding of the penile implants, their impact on your lives, their impact on your patient life. And until next time, take care and stay informed.